Today, we begin by defining emotion, a concept that sits at the intersection of psychology, physiology, and human behavior. Emotion can be described as a state of feeling involving cognitive interpretation, physiological arousal, and behavioral expression. In healthcare, and especially in midwifery, understanding emotions is not just academic, it profoundly affects communication, clinical decision-making, and the patient experience. Emotions share several common characteristics. First, they are triggered by internal or external stimuli. A memory, a diagnosis, a contraction, or even a facial expression can evoke a response. Second, they result from appraisal of stimuli, meaning our interpretation shapes the emotional outcome. Third, the body responds physiologically. Emotions can accelerate the heart rate, alter breathing patterns, or trigger stress pathways. Fourth, emotions include behavioral tendencies. We may withdraw, seek support, speak sharply, or express warmth. Finally, emotions involve eliciting stimuli, or cues, that evoke similar responses in the future. This complexity is precisely why managing emotions in patient care requires sensitivity and skill. We generally categorize emotions into primary emotions, which are universal and straightforward, such as fear, anger, disgust, anticipation, joy, and acceptance. Beyond these, we experience combinations known as mixed emotions. For example, a birth partner may feel joy and anxiety simultaneously. More nuanced emotional states, such as love, awe, disappointment, remorse, contentment, or aggression, represent further cognitive layering. Recognizing this range helps clinicians interpret patient behaviors without oversimplifying them. Let's turn our attention to the theories of emotion. One key theory is the James Lange theory, which proposes that emotions arise from the perception of bodily changes. For example, situation, physiological response, emotion. A patient trembles first, then interprets that trembling as a sign of fear. This theory emphasizes the body's role in shaping emotional awareness. The Cannon-Bard model challenges the previous theory by arguing that emotions and bodily reactions occur simultaneously, not sequentially. According to this view, the brain processes an event and immediately triggers both the subjective experience and the physiological response. A third influential model, the Schachter-Singer two-factor theory, argues that emotion stems from physiological arousal plus a cognitive label. The key idea is that we interpret arousal based on environmental context. For instance, a rapid pulse during labor may be labeled as fear or excitement, depending on the individual's interpretation. Measuring emotion is challenging because much of experience is internal. However, we use several approaches: self-reports, including interviews and questionnaires; observation, such as analyzing facial expressions; physiological indicators, including heart rate, EEG readings, or respiration changes. No method is perfect, but together they offer insight into emotional states. Emotions can be grouped into positive and negative states. Positive emotions include love, laughter, hope, optimism, and confidence, experiences linked with resilience and well-being. Negative emotions include anger, fear, sadness, boredom, and guilt. These emotions are natural, but persistent negative patterns can affect health outcomes and patient engagement. Emotions activate the autonomic nervous system, which produces measurable physiological responses. Breathing patterns may shift. Heart rate and blood pressure often increase. Pupils may dilate. Saliva production decreases. These changes prepare the body for adaptive action, but prolonged activation can be harmful. Anger specifically illustrates these physiological responses clearly. Increased energy production and blood sugar. heightened GI activity, muscle tension and tremors, altered brainwave patterns, activation of fight or flight mechanisms, including erect body hair. Understanding these responses helps clinicians differentiate emotional distress from medical symptoms. Anger often arises from the perception of unfair treatment or unmet expectations. In patient settings, triggers may include pain, fear, loss of control, or ineffective communication. Physical manifestations include faster heartbeat, sweating, muscle tension, headaches or flushed face, nausea or tremors. Recognizing these signs supports more compassionate and effective care. Managing anger constructively begins with recognizing triggers and building positive response habits. Two domains are important: physical responses, such as controlled breathing or walking away temporarily; mental responses, such as reframing thoughts, reducing confusion, or addressing irritability. Behaviorally, anger may express through yelling, swearing, withdrawal, pacing, or object throwing. Identifying behaviors allows intervention before escalation. Unexpressed or unmanaged anger can lead to depression, anxiety, and sleep difficulties. Harmful coping mechanisms, including substance abuse or self-harm. Physical consequences, such as gastrointestinal issues, circulatory strain, or blood pressure changes. As midwives, supporting emotional health is part of holistic care. Effective strategies for managing strategies include taking space or a break, engaging in physical activity, talking to someone neutral, using distraction techniques, practicing controlled breathing, writing thoughts down, returning to the issue later when calm. These techniques promote emotional regulation and prevent harm. Emotion is a central part of human experience and clinical practice. Understanding emotional processes helps midwives respond with empathy, clarity, and professionalism, especially when patients face fear, vulnerability, or intense life transitions like childbirth.